Good day, everyone. I am honored to have been invited to this session of the Asia eHealth Information Network. I will have to admit that I am not an IT expert, and I really had my reservations on whether any talk that I will deliver will be of interest to the group. The other, Alvin, Dr. Marcelo, however, convinced me to still go ahead and present our work to you. Dr. Marcelo got wind of our project because I had requested him to join this effort, but only after we were done with it, and this is also probably why he put me on the spot for this talk. But this, as you will hear later on, would only be partly true. Everything, it seems, has been appended by the pandemic, and my being here may be a byproduct of the confusion. In any case, I hope that whatever I will cover will still be of value to the participants, and I also hope to learn from everyone in the subsequent discussion. Please allow me to start off from when all our troubles began. It is now a year since a previously unknown virus made its presence felt, and soon after changed much of the world as we knew it. We have our own stories about this. But for the next few minutes, I hope you will bear with me as I tell you the story of how a virus caused 6 surgeons to come up with an electronic book. I will go into the why, how, what, and was it worth it of this experience. Sometime in March 2020, with the pandemic already wreaking havoc in many countries, and with previously unimaginable lockdowns already in place even in the Philippines, an Italian group came up with what was a prescient, if not ominous, document. With its hospitals overwhelmed by patients suffering from severe pneumonia, the authors gave ethics-based recommendations on matters such as ICU bed and ventilator allocations. I would soon after be part of another group in the University of the Philippines, Manila, that, knowing how developed countries were so adversely affected, were therefore concerned that it was only a matter of time before we would be in a worse situation. We thus worked at coming up with local guidelines for inpatient critical care. As part of this process, we undertook a series of online public consultations. Dr. Mela Lapitan, a colleague from the Department of Surgery of the Philippine General Hospital, participated in the first consultation. She asked for guidance on surgical services. Her comment was duly noted and also duly shelved. We felt we had to deal first with more pressing concerns, like, again, ventilator use. 2 of our team members were, after all, pulmonologists. We came up with a final set of recommendations and presented these in a public online conference. And I thought that was it. We had taken care of the need for urgent ethical guidance for critical inpatient services. Many people were happy with the guidelines, which, among others, paved the way for a greater acceptance for advanced directives. But Dr. Mela was not happy at all, as we did not include anything on surgical services. Before long, she asked for my help to pursue this. Not knowing any better, I agreed to assist a friend in need. Fortunately, the Philippine General Hospital had a call for research proposals. Dr. Mela, an avid researcher, jumped on the chance and filed a proposal. To my surprise, I learned that she had designated me as the lead, which now makes me wary of having friends asking me to do anything. Dr. Mela gathered a team of residents and fellows from the Department of Surgery of the Philippine General Hospital. The institution had been converted to a dedicated COVID-19 center, and trainees had a lot of free time on their hands, well, at least initially. They also had research requirements to fulfill, and Dr. Mela was, of course, the faculty whom they had to contend with for this. On May 11, at the height of an ultra-strict lockdown, during which I had to go on disguise as a surgeon in a scrub suit rushing to an emergency case, the team got together to map out what needed to be done. Foremost, we had to obtain as much information as we could. We thus embarked on what soon became an extensive literature research spanning international and local sources. We looked at a spate of journal articles, including those related to previous pandemic interventions. It was really fortunate that during this global health crisis, access to digital information became more liberal. In particular, established publishers of scientific journals opened their doors and allowed early and free distribution of COVID-19 related reports. Though some of the conclusions of the initial studies, often descriptive in nature, were subsequently found to be questionable, the ease of publication also meant that findings to the contrary could just as readily be disseminated. We also looked at ethics references, including the codes of the Philippine Medical Association, as well as the Philippine College of Surgeons. We went over position papers, legal and administrative documents, and a whole lot more. We then had to settle how we should best present what we had gathered. Our funding support was for a research project. But while a research manuscript along the lines of a review report would have been academically sound, this would have little value in addressing the demands of the pandemic. And so we arrived at stories. We thought of what would have been problematic areas, admissions, emergency surgeries, and started coming up with stories for these. And the rest came naturally. We painted scenarios, asked questions, pointed out why these were important, discussed the relevant ethical and technical details, and summarized the main points. We applied this storytelling formula across what we soon realized was turning out into a book. The different chapters were developed iteratively, with authors coming up with the drafts and building up on these over the course of time. Everything, of course, was done electronically. The writing and editing process was conducted in bursts, as all those involved had increasing clinical commitments in the succeeding weeks. The team never met in person again, so all the exchanges were done virtually. While all of us were surgeons, none of us were experts in all the surgical fields, much less highly competent in ethics. And though we were able to gather tons of theory and empirical evidence, we were not really sure if these were valid or practical. Thus, we actively sought out peers to go over our work. The first draft was sent to them on June 24, and they were asked to answer guide questions as well as give their comments ad libitum. Many did the latter. Based on the reviewers' feedback, we rewrote our stories and discussions. We even had to add on a new chapter. Things were becoming so complicated that we had to resort to a concept map to double-check what went where and also be sure that we did not miss out on any important ethical or technical detail. We ended up with 17 reviewers who represented a varied demographic. Some had two hats, such as the bioethicist who was also a lawyer. We tried to get more reviewers from outside Manila. However, though many were called, few responded. Still, the crop of reviewers that we ended up with greatly helped shape the form and content of the book. On July 28, the second draft was sent out for review. We also started to work on the design of the book. The final form of the book took shape subsequently. While we wanted to ensure the wide availability of the book, we also attended to its intellectual property protection. The book has a copyright registered with our National Library. We made sure, though, that this was not restrictive. It is copyrighted as a Creative Commons work, free to share, requiring attribution and only for non-commercial use. On August 21, without as much fanfare as a tap on the send button, the electronic book was released to the staff of the Department of Surgery. It also made its way into various social media pages. Though freely available and downloadable, there was no corresponding electronic archive for it, not with the department, the hospital, nor the university. In the digital universe, therefore, it seemed as if it didn't exist at all. For this reason, we submitted the publication to an online archive in the UK, the Newfield Council on Bioethics. Fortunately, it was accepted there, where it now sits above works from institutions such as Johns Hopkins and UNICEF. We also realized that a digital book is not only relatively easy to put together and disseminate, it also lends itself well to updates. We are planning a second edition with at least 3 new storylines. Dr. Marcelo has submitted his part for this, which deals with telemedicine for surgical services. We hope to receive the other overdue articles, well, from other authors, and start the digital ball rolling again. All these have, we feel, been well and good, but have we made any difference? The alternative universe is, of course, if we did not start off our stories. There would still have been guidelines out there. Our Department of Surgery has an excellent operational handbook. The local surgical specialties have their own guidelines readily available online. But these would not have sufficed, as many of the problems faced then and now go beyond the scope, if not spirit, of these guidelines. Like most good stories, we end ours with some cliches. We believe we identified and filled in a niche. We rose to the challenge. We melded science with humanity. We took advantage of online and digital systems. We came up with a book which we hope most will find joy learning from. These are the storytellers. I am happy that Mela is finally happy. The same holds for Maui, Brent, Dean, and Sam. Surgeons aren't usually thought of as being preoccupied with thinking about a lot of things, much less writing about some serious stuff like ethics. But just like pulmonologists, we actually do. And as always, we get the job done. We are grateful to the Philippine General Hospital for supporting our project. We acknowledge the appreciation of our colleagues from the Department of Surgery. We are indebted to our reviewers and contributors. We are thankful to the network for having us today. I hope that our experience in digital publishing in a world made more reliant on remote communications has somehow been useful and relevant to you.
All right. Thank you, Dr. Alvin Caballes. I think Doctor also prepared hypothetical cases for us to view. So while I'm setting them up, maybe Dr. Alvin can introduce the cases briefly.
Yeah, good evening, everyone. Uh, I don't know how you view the presentation. As I told Dr. Marcelo earlier, I wasn't really sure if this was relevant to your group, but let's see. We'll be presenting a video containing, well, hypothetical cases, and let's see how you may react, and in the sense that you have to choose which patient will have to go to surgery. I think that's the end of the video. I would also like to say that this video was produced by TVUP. That's these are from the University of the Philippines, and this video was used in a previous presentation again of the book that we produced.
We have our reactors here. So before proceeding with the presentation of Dr. Mela Lapitan, maybe we can hear the thoughts of Dr. Men Sambat from Cambodia.
Hello. Yes, thank you for the presentation and also the video for the pandemic for the surgery team in Philippines. So that's great. This to the clinical skill, so that also good that the doctor can have this to reference. But for Cambodia, we don't have such like this for the digital book or any reference. But for we have only hard copy and guidance from the Ministry of Health, so that we respond for the COVID in Cambodia. So this great, but the video is too short. So maybe what the purpose of this video, because you saw the sick patient in emergency and then cut up. So how to address this sick patient for that in a video? Yeah. Thank you.
Yes, thank you, Dr. Sambat. Now we will proceed with our second reactor from Lao PDR, Dr. Thepotong Sursavan.
Good evening. Thank you, Dr. Alvin and your team for your comprehensive develop this guideline. Based on your presentation, I think during pandemic, everyone need the guidance, particularly the healthcare worker who work in the IPD, OPD, or emergency, and the surgical wards. Congratulations with you during the short time, but you and your team can develop the good guideline and include the important topics. I particularly know that your lessons are applicable for Lao context as well. I will say your guideline to my colleagues. And I think I discussed with Dr. Alvin, maybe I will translate into Lao. And if you don't mind, I will introduce my friends and my teacher who are a surgeon to know and to learn from you more, because I am the public health. But for the clinician, I would like to our college to learn from you more. Thank you. Thank you, Dr. Alvin. It's really useful.
Yes, thank you, Dr. Tepoton. Our next reactor is from Myanmar, Dr. Win Min Han.
Yes, thank you. Thank you very much, Dr. Calvis. It's very interesting guideline. And as you know, the Myanmar currently facing a big challenge of the COVID at the moment. And I personally have from my close friends who are working in the surgical wards, saying they have positive cases from their OT, and then a lot of surgery, and then nurse and OT nurse, all this stuff have to be isolated because of the finding of the positive case probably very close to the surgery or even after the surgery. So I guess the guideline, which is in terms of focusing on surgery during this pandemic, is really helpful. Yeah, probably this book could be translated to Myanmar, and hopefully it can different departments for the surgery. What I have a chance to have a quick look on the book. What I like the book is that it has different sections related to different types of surgery, so it may be kind of relevant to different fields as well, instead of a general surgery part. So I think the best part of the book is that it keeps updating, so people can integrate a different aspect of idea according to the timeline. So it's really interesting, and I will share this to the colleges who might be interested of this as well. Just have a quick question: is that possible that in the future it would be included in? I mean, it will be possible to include like which instead of ethical guideline, which aspect of the I'm sorry, which aspect of the surgery would be the most sufficient way, or would be the fast track way? I mean, like the presentation, the video presentation that we showed. So in terms of practical parts, it will be more interesting to see if there's some more part of the aspects included in the book. Yep. With that, I would like to thank the Dr. Alvin for sharing the book. And congratulations to the team for developing such a fantastic guideline. Thank you.
Yes, thank you, Dr. Win Min Han. Yes, Dr. Alvin.
Yeah, I have a question to Dr. Alvin. If there's actually an answer to the question, who goes first to the operating room of the three patients?
Yes, that's how we had wanted people to react to that. Earlier on, again, I'm sorry to everybody. There are two Alvins in the house. When somebody says Dr. Alvin, I don't know who people are referring to. So please be mindful of that. In any case, we ended the video it simulates what we have in the book. It presents a case, and you have to think about then what should you do. Now, anybody can think about it and give his or her choice. Who should we do the surgery on? Is it case 1, case 2, or case 3? There really isn't any perfect answer to this. A surgeon will probably answer differently. Two surgeons will have two different answers, and even non-surgeons can have opinions on this. So again, if you would like to weigh in, if anybody would like to say who among the three should go into surgery, that's perfectly fine, and we would appreciate that. The other Dr. Alvin, thank you.
Thank you, Dr. Alvin. But I think all of the Dr. Alvin until before I spoke was about you. So all of the gratitude goes to you, Dr. Alvin Caballes. Thank you.
All right, thank Dr. Alvin Caballes and Dr. Alvin Marcelo. We now proceed to the next presentation, and I think Mr. Dat can also react on this a little later. So the next presentation is by Dr. Mela Lapitan. Thank you, Dr. Mela Lapitan. Before we proceed with the question and answers, we would like to invite our participants to enter their questions in the chat box. And then we would also like to call on Mr. Dat for his reaction on the presentations.
Thank you. Thank you for your presentation. But in fact, this topic today is not related regarding to my knowledge, but I can tell several experience from Vietnam. In Vietnam, we in Ministry of Health we have the committee of the ethical the health ethical, and the committee will write decision or write act to guide the hospital and the doctors, the ethical for the for the treatment with patients in the hospital in our hospitals. Also have a committee is a committee to decide the status of the patient. And now in the digital age, Vietnam also implement emergency system. The emergency system I talk about the technical. and we have a pilot project to connect health system status with the IoT system with the vital sign vital sign health equipment even in the bus the emergency bus when the patient on the emergency bus, even the doctor in the hospital can check the status of the of the patient through the system and decide first how prepare the tools or the system and the facility for save the patient. Now is the but the system as the presentation is not implemented, and in Vietnam I'm not sure that have a system the same system is just implement in Vietnam. We always decide by the committee. These are the committees, the ethical committees for this. Yes, that's our experience. Sorry, because this topic is not fit with our knowledge. So I'm not much reaction for these topics. Thank you.
Thank you, Mr. Dat. Mr. Dat is an IT expert from the Ministry of Health Vietnam. While waiting for other questions, maybe Dr. Mela Lapitan can share other information or react on the presentation of Dr. Alvin Caballes. Dr. Mela.
Yes, thank you, Cha, and thank you, everybody, and good evening. Well, I just wanted to put my presentation in context now. So that was really just a sampling of one of the chapters, but I also picked some pearls from the other chapters in that book. Because we have a lot of technical references already out there guiding us on what to do for surgical patients during a pandemic, but as Dr. Alvin Caballes has said, the niche that this book is really trying to get into is that giving another aspect of consideration from among the surgeons and the other healthcare workers on the ethical values and considerations that must be also put in place when deciding for our surgical patients. So to answer the question posted in the chat box by Alvin Marcelo regarding, in the absence of, in a crisis situation where quick decisions need to be made, and ethical committees may not be able to convene to decide on which patients should be brought up at 3:15 p.m. in this scenario. We think that a pre-prepared scoring system, a system by which even the healthcare workers facing the patient can be guided on how to prioritize one patient on the other. A system that already also incorporates not just medical issues but ethical issues as well. Which types of patients or scenarios are given value in the society, and that can be given a higher weight or a bigger weight or a higher score in the priority systems. Like for example, in the department in the Philippine General Hospital, where we are implementing currently a prioritization system for surgical cases. We give a higher score for younger patients, not just for their better medical outcome prognosis, but also because they are younger. So the value given to them in the society is higher, so they get a higher scores in a way. And so you know, considerations like that can be put into a triaging system or a scoring system, so that ethical values of the society are also incorporated in the decision making at the onset, or that can be used in a situation where immediate decision making needs to be done. So that's what an additional aspect or guidance that we hope that our book will be able to give to the surgeons and the other people looking at and taking care of surgical patients. And I'm very happy with the reactions given, on the desire to share, of course, to your surgical friends, and the plans, if indeed you are serious about translating the book into your own language. Please just let us know, and we're happy that you can do that, so that it can even the value will be enhanced. Please let us know once you've done it, and if you need more help about the translations, you can, some explanations and the context, so that you can translate it better. We'll be happy to help you with that.
Are there any plans after the book? Of course, you mentioned about part 2 of the book, but even when part 1 and part 2 are out, is it just a book that will be available, or will you be creating a capacity building program around it as well? Dr. Alvin Caballes, Dr. Mela.
Dr. Marcelo, if I may, well, our immediate objective was really to come up with this output, and we hope really to influence practice. But again, things are changing. As right now, it wasn't as I would say difficult as it was in the early months, but that could still change. But at least this time around, we have this reference which we did not have before. By the way, if you don't mind, and I beg the indulgence of the rest of the participants, you have among you Dr. Peter C., who is actually a bioethicist, and you may want to hear from him on if he has any thoughts or reactions on this.
Thank you, Dr. Alvin Caballes. Dr. Peter, is your microphone on? We'd be happy to hear from you as well, Dr. Peter.
Yeah, I'm just listening in and learning from you guys, and I'm glad that your team has really extended this course on the convergence of ethics and technical issues in surgery. So congratulations, may your tribe increase.
Thank you. For Dr. Mela Lapitan, in crisis situations, there is a gatekeeper to the operating room system still, right? So
Yeah.
would it help if those gatekeepers in a pre-pandemic situation also at least be aware of the ethical framework? So at least when the crisis strikes and there is no, in their mind, have the ethical framework and apply it to the patients in front of them. Mela.
Yes, of course. Unfortunately, our book came a little bit too late. That's why the book is probably not for this current pandemic, or this current crisis, but maybe more for the future. Hopefully we don't get it too soon, but for future events, then yes. As I said, even just creating that scoring system, that must be in place already for the next pandemic crisis. I suppose value systems will not change that much or immediately, so those can be incorporated already. And then once crisis and really resource constrained situations come in, then indeed that is when the new, like for example, the scoring systems can be triggered for use. So definitely ethical principles, ethics training should really be, I mean, for one, when preparing for this book, it really opened my mind, you know, how all these considerations that must be in place already when real crisis situations come in. And it was really an eye-opener for me personally. So I guess it will be the same for the rest of the healthcare workers faced in the ER, in the OR as well. So yeah, we hope that we can really do this training for ethics for the hospital staff.
I'm still intrigued with the answer to the question if it's the young man, the woman, or the old man. I think it's like a puzzle that Dr. Alvin Caballes opened and is not going to close in this webinar. But I think exercises, even before crisis situations, would really help a lot. And more or less practice. You put the gatekeepers of the operating room system practiced and regularly aware of the framework so that when the crisis hits, whether it's a tsunami, an earthquake, or a pandemic, then they can just, like ABC for trauma, they can quickly remember what they have to do in terms of prioritization. Do you have any idea of the scoring system already, Mela?
We are, as I said, we are implementing one, but this is what the scoring system that we're using now is really more for the elective patients. A very strict scoring system. It was really based on the MENTS scoring system published, but we, of course, where the ethical values and considerations came in and the realities of the situation in the Philippine General Hospital, that led to the modification of the MENTS scoring system. So it took into consideration, as I said, you know, patient characteristics, but as well as whether, you know, a certain intervention is available or not, whether that intervention needs patients to keep coming back to the hospital. Those are the, you know, those are the considerations that were put into the new scoring system as to whether and then whether this patient will need ICU or not. Actually, in this pandemic situation, patients needing ICU scored lower than those who do not need an ICU. So that just gives you some idea where it's not automatically the sickest patient that gets the operating room slot, but really more on who will benefit most and who will benefit the society most, actually, who gets the operating room slot. So yeah, we have that scoring system, and it's in the book. It's referenced in the book as well.
Okay, thank you. I think we've reached the top of the hour. Thank you, Dr. Alvin, Dr. Mela, Lapitan. On behalf of the Asia eHealth Information Network, I'd like to thank our speakers, Dr. Alvin Caballes and Dr. Mela Lapitan, and also our reactors. So we'll see you again in our next AeHIN Hour. And I hope if you are interested in the translation, please contact the authors directly or through me if you did not get their email addresses. So good night, everyone. Thank you. Take care. Stay safe.
Thank you.
Bye-bye.
Bye. Good night.
Good night.